Welcome to the very first episode of Udeozor's Next Chapter on the Udeozor Nursing Network. That would be UNN. So, we have our very first guest. I'm very excited about her. Her name is Dr. Alleyne. She is a board certified
general surgeon,
she's a board certified general surgeon specializing in
breast cancer surgery.
and I am very proud to let everyone know that she is actually my sister. Okay, so I'm going to be channeling Oprah today. Again, this is UNN, Udeozor's Nursing Network. So I'm going to be channeling Oprah, okay? Hair and makeup, we need Andre. If I over channel and get on your nerves, I want you to just ring this bell.
No problem.
Sisters can be like that. So let's get down to business. We are here today to talk about the very important issue of breast cancer. And since Rebecca's a specialist, I figured let's bring her in and get some great information for nurses. So the first question I have for Dr. Alleyne is, can you talk about the prevalence of breast cancer in America?
Sure. Every year there are about 240,000 people who are diagnosed with breast cancer. Most of those are women, but the reason I said people is because about 1 out of 100 of those are men. So about 1,000 men every year get breast cancer.
Okay. I'm going to go from prevalence, and we're going to talk more about the actual disease. But in terms of prevention and mammography, how often should a woman get a mammogram?
Well, most physicians will recommend that women get mammograms every year starting at age 40. There are some new guidelines that have come out that state that people can get mammograms starting at age 45, but that is only if they're at average risk for breast cancer. There are several risk factors. Most people think of family history immediately, but there are other risk factors like childbirth, if you had your first child after 20 years after your first period, if you've never had children, if you have a condition called dense breast tissue where mammograms don't the x-rays don't pass through your breast tissue very well, all those are actually risk factors for breast cancer that would put you into that start at age 40 category, not at age 45, which again is only for people at average risk.
Wow. So not having children, having your first child 20 years after your first menstrual period?
Correct.
Wow. All put women at risk.
Correct.
Okay. I want to address some things that are kind of going around. What do you have to say to these people who say the mammogram causes breast cancer? It smashes up the cells and creates a cancer in the breast. I know you've heard that.
Yes. Well, pressure on the breast for the amount of time that you're doing a mammogram is not going to damage the cell enough to cause cancer. One of the things that associates increases in cancer with mammograms is the fact that mammograms pick up cancers that we can't see. So they're going to pick up cancers that we would not have seen before mammogram or in someone who's never had a mammogram. So it appears that that mammograms make the cancer increase, but they actually don't. They're just picking it up at a much earlier phase.
I see. So it is not causing cancer.
No.
Okay. And then there's been some recent reports about detection and the rates of detection with mammograms. What do you have to say about that?
Well, that goes again back to the dense breast tissue. What we've discovered lately is that for women who have dense breast tissue, and by dense I mean it's made of more glands than fat. That is, breasts that don't sag because fat kind of hangs and is under the effects of gravity, but are more perky. In that type of breast tissue, mammogram alone may not be the best screening tool, and it's definitely not the best tool if you feel a lump.
Okay.
So if you feel a lump, you have dense breast tissue, they look at your mammogram and your mammogram looks normal, you should have a follow-up test called an ultrasound.
Breast ultrasound.
Breast ultrasound.
Okay. So how often do you recommend breast self-exam, and what time of the month should women be doing that, examining their breasts?
Breast self-exam is still recommended. We don't recommend that doctors teach it because every woman has their own method of doing it. So whichever way you can feel your breast comfortably, please go ahead and do that. We do recommend that it be done once a month. And in women who are menstruating, they should pick the same time in their menstrual cycle. So your breasts feel different a week before your menstrual period as opposed to a week after your menstrual period. So don't do it a week before 1 month and a week before the next month. Always do it, say, 1 week before.
Okay.
So you're examining your breast in the same state in your menstrual cycle.
Got it, got it. So the bottom line is we need to do our breast self-exams and we need to get mammograms despite all of the things
confusing things that you see.
So you get a mammogram, you get a mammogram, you get a mammogram, you get a mammogram, you get... Okay, sorry. All right. So, you mentioned risk factors that sounded like they were not modifiable. I want you to talk about risk factors that are modifiable, meaning risk factors that we have control over and that we can actually change.
So, 2 things that you've probably heard you should stay away from in the past. Smoking, cigarette smoking increases the risk of breast cancer by 30%.
Wow.
Also alcohol. There are studies that show that women who have more than 3 drinks a day have an increased risk of breast cancer. And again, a drink is defined by volume. So for wine, that's 6 ounces. Beer, I think it's 10 to 12.
Not those Olivia Pope glasses.
No, not so the one Olivia Pope glass may in fact be your 3 drinks. You know, if you're drinking out of a 12-ounce glass, you're probably pretty much there.
Okay.
So the reason behind that is estrogen is cleared by the liver, just like alcohol. So if your liver is really tied up with clearing out alcohol, or it has damage from heavy alcohol use, cirrhosis, which is a scarring of the liver, then it doesn't do as good a job of clearing the estrogen out, and your breast cells are under the influence of estrogen longer than they need to be, and they're more prone to developing a cancer.
Too much estrogen.
Excessive estrogen in all those things I mentioned, late childbirth, no childbirth, early first period, late menopause, those are all related to estrogen. They're all related to unopposed estrogen exposure is what we call.
Got it. Very interesting. So let's talk about Black women and breast cancer. I've heard that Black women die more of breast cancer.
Yes, that's correct. Black women actually overall have less breast cancer. So if you took a wide age range of white women, say 21 to 90, and a similar group of Black women aged 21 to 90, the Black women would actually have less breast cancer overall. However, Black women are more likely to get it before age 50, and they're also more likely to die of it. And that's even when we match for what we call staging, checking whether it's gone to the lymph nodes or to other parts of the body, the mortality or the death rate remains higher for Black women in the U.S.
Well, we always got to be the dead homies.
No, we don't.
I remember you saying Black women have good bone density and other things. Yes. Anyway,
no wrinkles.
We're all at risk. So I want to talk about treatment. Can you describe the treatment plans if a woman is recently diagnosed with breast cancer? What's the action plan? Sure.
The first thing you want to ask is whether you're going to have a team of physicians and how that team of physicians is going to communicate. Breast cancer is never treated by one specialty. I'm a surgeon, so my job is to do the removal of the physical parts, the lump in the breast, perhaps some lymph nodes if there's evidence of spread to the lymph nodes. However, there's always several other specialists who are involved. The mammogram is done by the radiologist. If there is cancer in the lymph nodes, or if the tumor is of a large enough size, we usually recommend something called systemic therapy, and that can either be pills, which are estrogen blockers, called tamoxifen is one pill, Arimidex is another pill that we'll give that block estrogens, or there are other treatments that we give in the veins called chemotherapy. Those are given by a specialist called a medical oncologist.
Okay.
And some women, all women who have breast sparing surgery, breast conserving therapy, will need to see a physician called a radiation oncologist, and they will administer a dose of radiation to the area where the tumor was in the breast. Then you have other specialists that the patient may not see, like the pathology doctor who's looking at the specimen that's removed and is saying what type of cancer it is, whether it's present in the lymph nodes. They're very important because all the other treatment that follows is based on how accurate that pathology reading is.
Mm-hmm.
And of course, you have people like the anesthesiologists who are going to come in the OR and put you to sleep.
Mm-hmm.
Women who get reconstruction may have a plastic surgeon.
Mm.
So you want to know who is my team of doctors going to be, and how are they communicating? Do they have a weekly conference? Are they communicating by email? Can they all look at the x-rays at the same time and discuss them?
Mm-hmm.
That's a very important aspect of cancer care, is
Okay.
communication within the various disciplines.
Okay. What advice would you give to nurses caring for post-op mastectomy patients?
The first thing I would say is be compassionate. Most women are at an age where they're kind of what we call the sandwich generation. They may be taking care of an older parent.
Mm-hmm.
They may have kind of grown children at home. Maybe have children and grandchildren at home.
Mm-hmm.
So they're often very anxious, not only about their own condition and their mortality, but also about the things that they've left sort of undone at home while they're getting their treatment.
Mm-hmm.
Also, pain control is very important. Sometimes the surgery in the armpit can be painful, so we want to make sure that we're communicating with the patient, getting that pain scale done. Some people have self-administered anesthesia, but obviously if they don't, it's up to the nursing staff to find out and get the orders from the physician about
And
how-
advocate for them.
Right, advocate for them.
Excellent. Okay. What else did I want to talk about in terms of breast cancer? What about this BRCA gene? Talk about that.
Okay, so everybody actually has the BRCA gene.
Okay.
What it does is it basically functions like a spell checker. Everyone's genes, everyone's DNA makes little mistakes every now and then when the cells are copying and kind of rewriting the DNA. BRCA gene's job is to go through and say, if I was trying to type out this and I wrote HTIS, BRCA corrects it and says, no, what you meant was THIS.
Okay.
Some women, Angelina Jolie is kind of a famous example, have a mutation where their spell checker gets broken. Either they were born with one broken copy and then the second copy wears out, or they were born with no copy at all. Those are usually women who develop cancer very early. So if that spell checker is broken and you're trying to spell this and it comes out HTIS, there's a mutation there, and it's often a cancer-causing mutation. It can cause cancer in the breast, and in the BRCA1 mutation often causes cancer in the ovaries.
How do you know if you have this gene?
So most women who have it will have a family history of breast cancer.
Okay.
They'll have a close relative with breast cancer, possibly multiple close relatives, and many times those relatives are diagnosed at an early age, under age 50. However, one thing I always want to caution people about is people assume that this can only be passed from mother to daughter, but the gene is what we call an autosomal dominant. So it's inherited exactly like brown eyes. You can get it from your father. You can get it from either side of your family, and you only need one copy of it to have the mistakes made in the spell checker. So your dad doesn't have much breast tissue and doesn't have any ovaries. So if your father's father's mother had breast cancer at age 28, and all of her sisters did, but they were back in Poland or Trinidad or wherever, you may not know that. But you may have received the gene because there are two generations of males in between you and that person who the gene showed up in. So we want to know about our father's side, and we want to know as much extensive family history as possible.
Wow.
As many generations back as you can.
So with that mutation, the risk for ovarian cancer is very high.
The risks for ovarian, I believe, is, if you have that BRCA1 mutation, I believe is 40%, and breast, I believe, is 60%, but you can feel free to Google check me on that.
Okay. That won't be on the test.
Okay.
Good information. Well, this has been excellent. Andre never joined us for hair and makeup.
Oh, well.
Stedman! They went to lunch. Anyway, I very much thank my sister for coming.
Yay!
a nurse, she's a doctor.
Yay.
Venus and Serena of medicine.
She's more organized.
I'm Venus.
Right. The original.
Thank you for joining us.
Yes, thank you so much. Thanks for having me.
Our very first guest on Udeozor's Next Chapter.
Yay, so proud of my sister.
I'm proud of my sister.